Hello everyone. All doctors who are actually watching us from Facebook, Instagram, a very good evening. Today we have a very exciting case to discuss. I know many of you must have read therapeutic guidelines, a little bit of concept from the therapeutic guidelines, and a little bit of concept that you need actually in your day-to-day practice. So let's see this case first. This is about a 59-year-old woman. So we are talking about an elderly person here, a 59-year-old woman, presents with intermittent pain from the mandibular left second molar. Clinical examination reveals extensive periodontal attachment loss. So even the clinical examination has been given to you, reveals an extensive periodontal attachment loss, grade 2 mobility, percussion involvement, and heavy supragingival calculus despite acceptable plaque control. A very good point here that we can eye on. First thing, as I read here, extensive periodontal attachment loss, grade 2 mobility, furcation involvement, right? Furcation involvement and heavy supragingival calculus despite acceptable plaque control. So roughly I am going towards a stage 4 situation here. At the moment not specified, but I'm taking that into account from the question or from the information given to me. Also, it mentions acceptable plaque control. Even having an acceptable plaque control, we can see the destruction is quite a lot. Extraction is being considered. So the lady mentioning about that she has pain from her left second molar and we are considering extraction for it. Her medical history includes end-stage kidney disease. Now, this is the most highlight part of the question. When you read questions, read every part of it carefully. When I talk about medical history, let's break it down. It clearly mentions end-stage kidney disease. Now, if you are preparing for your exams, we know when we talk about end stage kidney disease, right? End stage kidney disease and end stage liver disease, all these people are falling under immunocompromised state, immunocompromised situation, right? And when you talk about ASA classifications as well, this ASA classification for this individual will go towards ASA 5. So now I am going towards the next part. Let's see, we have mentioned the patient has a end stage kidney disease secondary to long lasting hypertension. Secondary to long lasting hypertension, that means the patient has a history of chronic hypertension for a long time, right? Long standing. Type 2 diabetes mellitus, also having a type 2 diabetes. She has been receiving hemodialysis via a left forearm arteriovenous fistula for the past 4 years. Now, very important, we know she is having an end stage kidney disease and she is also receiving dialysis, which is hemodialysis via a left forearm arteriovenous fistula. Now, when you talk about dialysis, we will go and deep into dive what is dialysis and why we are doing it. But let's now, for this situation, let's remember that yes, she is having a hemodialysis for the past 4 years. Not recently, but past 4 years, right? And attends dialysis session every Monday, Wednesday, and Friday. That means if I make sure to remember the dialysis days are Monday, Wednesday, and Friday. Now, she is currently undergoing assessment for kidney transplantation. So, the kidneys are actually compromised to that state that we are actually looking for a kidney transplantation for her. That means the kidneys are definitely not functioning even the minimal amount that we need, right? So we are looking for a kidney transplantation at this point of time for this patient. Her medications include insulin, which can be easily related to your diabetes, amlodipine, because she was having a long-standing hypertension, aspirin, sevelamer, and erythropoietin injections. Now, sevelamer, what is sevelamer? So, sevelamer is something which is given to kidney patients to prevent phosphorus binding. Okay. And erythropoietin injections, because these people where the whole immune system is compromised to this stage, right? So what is happening? A lot of tiredness, a lot of fatigue, right? We are not able to uh, release the toxins. If you are not able to release the toxins from the body, definitely the nutrient part which you are consuming as well is not working for the body. If you are not getting the nutrition part, definitely the RBC count, the red blood cell count will drop down. So erythropoietin injections as well are being given to this patient. So we now understand end stage kidney disease compromising the patient, right? Putting the patient on a hemodialysis since past 4 years. Patient is having dialysis on Monday, Wednesday, Friday, and also is looking for a kidney transplantation. The medications also has been mentioned to you. The patient reports persistent dry mouth, a metallic taste, halitosis, and occasional burning of the tongue. Now, dry mouth, metallic taste, halitosis, occasional burning of the tongue. These are quite common symptoms that we see when we talk about end stage kidney disease, end stage liver disease, because the body is holding off with the toxins, right? The release of toxins is not happening. If the release of toxins is not happening, then definitely you tend to have that halitosis, tend to have the bad breath, sometimes a fruity odor. Um, and then, yes, as mentioned, occasional burning of the tongue, dry mouth. Examination reveals generalized periodontitis and mild angular cheilitis. Also, from our examination, we have seen generalized periodontitis. At the outset itself, I mentioned looking like around stage 4 periodontitis and mild angular cheilitis. A recent panoramic radiograph demonstrates generalized reduction in trabecular bone density. Please please understand this. They are not, or they have not given you straight away about the loss of periodontium here. Highlight part was trabecular bone density. Trabecular bone density is reduced. Thinning of cortical bone is happening, and several poorly defined radiolucent jaw lesions. Now, why this is all happening? So, this is like a dystrophic situation. It is just destructing the jaw when you talk about dystrophy, right? Why it is destructing? We know the patient is having an end stage kidney disease, right? End stage kidney disease compromising the immune system, even compromising the health of your jaw bones, right? Now, these are very specific features that we see in an end stage kidney disease, where you see reduction in trabecular bone density, thinning of cortical plate, and severely poorly defined radiolucent jaw lesions. This whole presentation is named as something called as renal osteodystrophy. So, because of a systemic disease, we are seeing some oral manifestations and radiologic findings. So, because of your systemic disease, I am seeing the destruction in the jawbone, and that's why, as named, renal osteodystrophy. The patient attends your clinic on Wednesday afternoon, which was basically her dialysis day, if you remember, right? Monday, Wednesday, and Friday. So, patient attends your clinic on Wednesday afternoon immediately after completing hemodialysis. Now, a lot of information which we have broken down right now. We have tried understanding what medical condition this patient has, what medications this patient is taking. This patient is also having hemodialysis on specific days, and now he's presenting to you on a Wednesday afternoon. Now, just to give you a little bit of an idea how it looks like, renal osteodystrophy, you can clearly see some osteolytic lesions, radiolucent lesions. You can see the massive destruction in this patient, right? Now, going towards the actual question, this was presentation of the patient, right? Now, let's see what is your actual question and how do we come to the answer. So, question was, which recommendation would be least appropriate for this patient? Option A says encourage meticulous plaque control and regular periodontal maintenance. What did we read from the scenario? We read that yes, the patient has something called a stage 4 periodontitis. If I take all that into consideration, if I take the radiograph into consideration, right? When I talk about stage 4 periodontitis, we know they need even more frequent cleans, deep cleans, right? It's not like a normal individual that we tell them to come in 6 months and get their cleans done. As per your periodontal classification, it's clearly mentioned 3 to 4 months, right? So meticulous plaque control is needed. Yes, this patient is trying to keep up with an acceptable plaque control, but we will still need a good plaque control in this patient because you can see the destruction is progressive. The destruction has not stopped, the destruction is progressive. On top of it, when I talk about uh, end stage kidney patients, right? What happens in end stage kidney disease? End stage kidney disease, they are holding on with the toxins. Holding on with the toxins, commonly your urea. So your blood urea is increasing, which is in turn activating the bacteria in the saliva to produce more ammonia and precipitate more calcium salts, leading to more calculus formation, right? So definitely in such a situation, yes, meticulous oral hygiene is needed. So, going back to the question again and trying to understand here, when you see here, which recommendation would be least appropriate for this patient? Encourage meticulous plaque control and regular periodontal maintenance. Yes, as per the condition given to me, as per the presentation given to me, as per the systemic condition which is presented, that is most appropriate. The question is asking you what is least appropriate, right? Now, option B says advise prompt assessment of any future oral infection. For sure, if this patient is holding on toxins, if this patient is holding on that much of toxins and it is not released from the body, he is prone to infection. If he is prone to infection, why the word prompt has been given? The patient is immunocompromised, guys. The patient is immunocompromised to such a stage that we are actually deciding for a kidney transplant. If there is any oral infection which is not promptly assessed, can lead to massive destruction because the time duration this patient will face for that destruction will be less as compared to a normal individual because his immune system cannot fight back the infection. So, advise prompt assessment of any future oral infection is needed in this medical condition for sure. So, it is appropriate, it is most appropriate. Option C says encourage increased fluid intake to reduce xerostomia and improve salivary flow. Now, if I consider xerostomia as its own, just as its own as a condition that we determine in individuals, we give them some treatment planning, we give them solutions for xerostomia, right? Cutting on the caffeine, cutting on the coffee, tea, right? Cutting on the smoking and increasing the fluid intake, right? Now, in this patient, if I take this into account, encourage increased fluid intake to reduce xerostomia. I know he is having a dry mouth situation, but is this option appropriate for a patient who is having a end stage kidney disease and who is on dialysis? This has to be taken into account. So what does dialysis means? So dialysis, if I just roughly break down in a normal terminology, di means something across or through, like how I draw through a line between this circle, right? That's a diameter. So di means going across, lysis means loosening, cutting, separating out, right? So what is happening in a dialysis? You are going across and you are removing or loosening or separating out all the toxins, the blood toxins, the waste product which is accumulated in the kidney. So you are trying to remove that, right? Now, when we are trying to remove all this waste product from the body, right? On the day he is getting a dialysis done, you are actually removing the waste product from the body. What we try to tell this patient as a precaution, we try to restrict their fluid intake. A machine which is placed to remove the waste content, if you overload the machine which is removing all this waste content, if you overload it, right, it will be hard for the machine, for the patient. Now, why? Dialysis, you are removing the waste product, right? Removal of the waste product is happening. Okay. So, if you are removing the waste product, it is actually decreasing the fluid overload in the body. But supposedly, if I don't restrict this patient from having fluids, right? If I tell, okay, you should drink enough fluid. If I tell him to drink enough fluid, right? What will happen? There will be a fluid overload in the body. That fluid overload in the body will in turn affect your heart, will in turn affect your cardiovascular. The patient is at risk of having a heart attack. So, what has to be done for a dialysis patient? Usually, we restrict them. We restrict them from fluid so that we can decrease the fluid overload. So, this dialysis patient have some restriction, right? So that there is no fluid overload. If this is the thing which we are following for a dialysis patient, does this option sound correct? That is encouraging increased fluid intake to reduce xerostomia and improve salivary flow? No, because they are actually on a restricted fluid intake. So let's see here as well. This is from your therapeutic guidelines, which I have just pulled out. Increased urea in the saliva is also thought to promote calculus formation, right? Patients with kidney failure may also have a higher risk of caries if they have risk factors such as reduced saliva. Okay, common complications that they have given, which includes basically anemia caused by decreased erythropoietin production. That's the reason the patient is actually on that injection. Okay, then you have cardiovascular disease. This happens because of a fluid overload. Complications, yes, fluid overload is clearly mentioned, right? Now, let's see on another slide. What happens if you take too much of fluid? Drinking that too much of fluid will put extra pressure on your heart, as I mentioned you. In the short term, it will cause high blood pressure, shortness of breath, and swelling. Now, when I say restricting the fluid, what all fluid has to be restricted? It's basically any water, tea, coffee, right? Soft drinks, milk, ice blocks, wine, beer, soups, jelly, like everything has been clearly given to you that what fluid has to be restricted. But yes, now if I go back to my options, you can clearly understand that this option is least appropriate, and I would say not at all appropriate. We are not encouraging a dialysis patient to have an increased fluid intake. Option D says ensure dental treatment planning takes hemodialysis schedules into account. Now, this is really important if a patient is mentioning you that he goes under hemodialysis, I keep that into account while doing my treatment plan, like what day I have to schedule the patient. Now, I will take this point a little bit in detail for the next question. But yes, for this question, what is the most appropriate are A, B, and D? And the question was asking what would be the least appropriate, and your answer is option C is the least appropriate. Now, those who are on live and those who tried solving it, I hope you must have now understood the concept why option C is least appropriate for this patient. Okay. Now, going to your next question, which is actually a connecting question for your option D. So let's see this question. You decided that extraction is required. Which is the most appropriate appointment time? Okay. I have decided that I will extract the tooth. Okay. Patient is having dialysis on Monday, Wednesday, and Friday. Right? Now, we already mentioned in the previous question that whenever you are performing a treatment, you take the hemodialysis into account. Now, this question splits that hemodialysis even in detail, that which is the most appropriate appointment time. Now, option A says Wednesday afternoon immediately following dialysis because excess fluid has been removed. That is a dialysis day. Friday morning before dialysis because anticoagulation has not yet been administered. Okay, we'll come to this point as well. Thursday morning patient is actually not having hemodialysis. Okay, he's not getting any dialysis. Monday afternoon, immediately after dialysis, is because uremic toxin levels are lowest. Okay, so Monday is also a dialysis day. Only option C is not a dialysis day. Now let's see, when you say dialysis, what is happening on a dialysis day? Like in this patient, he is on an arteriovenous fistula to remove all that toxin content since past 4 years, right? So what we actually do, there is a machine which is connected, which will remove all these toxins, right? So when this machine is connected and we are trying to put tubes and remove all this toxin contents from your body, what we actually want? We want it swiftly working. We don't want obstructions in between stopping that dialysis. We don't want any obstruction, right? Now, when the when you go for a dialysis, I don't want any obstruction. That means I don't want, when I say hemodialysis, I don't want any heme, any blood to get clot in the tubes or obstruct the machine from performing well, right? So I don't want any blood clots to be formed in between that will hamper my dialysis. So if I don't want any blood clot to be formed, as a precaution, the patient is put on anticoagulant. So the patient is put on anticoagulant, commonly used heparin. Okay. So if this patient has been administered with heparin on the day of your dialysis to make sure there are no blood clot formation, now comes your actual concept of extraction. When you are performing an extraction, and when I talk about anticoagulants, now you have read this part from your therapeutic guidelines as well. What do we take into consideration? There are certain considerations when patients are taking anticoagulant. So when I talk about extraction, yes, this person is going to bleed more because he is on an anticoagulant. What do we want after extraction? The bleeding to be stopped. You have an entire chapter of how to control bleeding, how to manage the bleeding, right? That's the first thing that I expect. In the next 1 hour after extraction, we expect, yes, the clot at least should form, the bleeding should stop, patient should throw away that gauze, right? Now, if the patient is already on an anticoagulant and if I perform an extraction, this patient is going to massively bleed. So the concept is, because this patient is administered with an heparin to perform hemodialysis swiftly, I don't do any extraction on the day of hemodialysis. right? So I don't do on Monday, Friday, Wednesday, as mentioned in your scenario. So, what is the best day? So, the best day is Thursday morning. Now, I hope this concept is clear that why we are performing an extraction on a non-hemodialysis day. Now, if you read this as well, this is from your therapeutic guidelines. How well you read it is important. Hemodialysis uses a vascular access point to access and pump heparinized blood, clearly given that a heparin is being administered through a dialyzer. So, yes, there are like small, small words in your therapeutic guidelines which are picked up, the concepts are being tampered, and then questions are being formed and asked in your ADC exam. But here, yes, we take each concept in detail to discuss and make you understand that why we do or why we consider these changes for our patient. I hope this short session would have given you a little bit of insight of how important it is to understand the systemic concept that we take into account while treating a patient who has medical condition. All good. Thank you so much, guys, for being there, and we'll see you soon for another session.